Any questions from the audience on any of it?
Thanks for sharing your expertise. My question is about the drudge. So in a reducible, unstable drudge with, let's say, either a bony or a soft tissue TFCC pathology, is it acceptable to just pin it? When should you be doing a TFCC procedure specifically? Is there any outcomes data to suggest there's a difference?
Well, our expert of the ulnar corner is going to answer that one.
There, okay. I think that, the way that I think about it, if it's bony, you should fix it, right? So if it's that dorsal lunate facet, like we showed here, go in and fix that piece. If it's that you are short, make sure you get length. So as long as you can solve for the bony side, you should be able to solve for the incongruity. Then you have to say, is there a soft tissue? There's no distal ulna fracture that I have to fix. If it's still unstable after all of that, and then the question becomes, do I pin it? Do I leave it in a long arm splint and supination? Or do I go in and do an open TFCC? The way that I think about it is certainly depends on how comfortable you feel doing an open TFCC repair, number one. So most people don't, unless they're a hand surgeon, feel comfortable doing that. So that's when you think about pinning. If you take it, the times that you're going to open it in like a trauma setting is if it's difficult to reduce that. You worry about the ECU being entrapped in the DRUJ, and that's when you need to make that dorsal incision to see if it's entrapped there. And sometimes that's when you feel like you're getting it reduced, but you're putting a lot of pressure into it. It should reduce really easy. And so that's when you pin it, and that was, the image that I had up there was it pinning. Otherwise, you can open it and fix it, and usually you do that for a basilar styloid fracture. And then the question is, can you leave it in supination? The studies on showing there is no great inter-observer reliability with assessing a DRUJ. So it's really hard. You and then the person sitting next to you might have a differing opinion on whether it's loose or not. But I do think it's worth looking at both sides. And if you decide that you're going to split it in supination, you don't. When I think about it, is it a little bit more lax than the other side? Is it more stable in supination? That's when I decide to just leave it in supination splint for 2 weeks. I actually don't know the results of that study that you were talking about in terms of.
It's published.
Yeah, I don't know the outcomes of those.
Michael.
Great session. Question for Kevin and the panel. Did the SWIFT study change your practice at all? It's a 400-patient randomized trial of scaphoid fractures where the non-operative group did surprisingly well, and there really wasn't a whole lot of difference in the return to work. So did that change your practice at all? What do you think?
No, because the way that they did the study is that they made them wait for 6 to 10 weeks in the non-operative and the aggressive casting group, and then they said if they weren't healing at that point, they actually shipped them off to have surgery. And what they don't talk about really in the study is that there were 17 people that had surgery from their aggressive casting group, and then 4 of those went on to non-unions. So they had a 25% non-union rate in that group. And so it actually didn't change. It's not going to make me more aggressive about casting. It makes me want to put screws in them more.
I mean, I don't think that study was really too persuasive, because the worst scaphoid fractures are the proximal poles, and I don't think anybody on this panel, would treat a proximal pole fracture in a cast. Would anybody treat a proximal pole fracture in a cast?
I would.
You would?
I would, because there's studies from, I think Ruby Gurwal actually looked at it, and then it's 90% union with casting. And so I was taught to put screws in it, but then I stopped doing it. I gave him the option. So
Okay.
I've changed.
All right. Any other questions? All right, I'm going to ask Tony first. He showed in his algorithm plates, so spanning plates. So do you think that external fixation has any role as a neutralization device instead of a spanning plate, or a spanning plate's completely done away with X-Fix?
Yeah, I totally think it does. I think it depends on your training, what you're used to, what you have available to you. In my trauma fellowship, I was actually trained to use X-Fix, not the dorsal spanning plates. It was only until I began practice that I started using dorsal spanning plates. But if I'm just using it strictly just maintain length, yes, it's fine.
Okay. Nikki, on patients that have unstable DRUJs after you get done with a perfect reduction and there's no ulnar styloid fracture, are you more or less likely to try to open and fix that or not? Patients that have instability without a fracture of the ulnar styloid.
Yeah, I would say I'm more likely to pin it, which is like probably blasphemy for a hand surgeon to say. But just in opening fixing the TFCC, they get really stiff in the setting of an associated distal radius fracture, particularly depending on where you've done your prior incisions. As long as it reduces well, I'm much more comfortable pinning it. But certainly we'll open it if there's advanced imaging that shows that there's a gross TFCC tear, which almost there never is at a time. You almost never image an acute distal radius fracture, but I pin it. I don't know what everyone else. Nico, I know you fix them.
Anybody have a different viewpoint?
So, so I look at the injury film, and if the injury film shows that the DRJ is clearly off, there's like a gap, and then you fix the radius, and it's unstable, then I'm actually going to open dorsally, even if it feels kind of soft, because I'm going to look for a tendon in there, maybe interposed. And even if it's not, then I could still extend that and then go after the TFCC. There is a systematic review on looking at pinning versus fixing it open, and it actually shows no difference. Actually, you do better if you just pin it, but you have to be careful with systematic reviews because it's all comers, right? And so I know what the data says. I used to pin it, but then in my hands, if I feel like comfortable fixing it, I'm gonna fix it.
I think just recognizing that it's unstable and doing something, even if it means a long arm cast in supination, is better than nothing. I think we're uncovering more DRUJ instability now because we played it and we want to move them early out of a splint. In the old days, they got put in cast for a long time. The thing had a chance to heal. We're not letting the TFC heal because we're moving it. That's the problem. So you got either do one or the other. You either immobilize them or fix it. And I'm in the favor of fixing it. I don't think it's hard to fix it. When it's torn and you make a small mid-axial incision on the ulnar border, you can see the tear, and you just loop a suture around it, put it to an anchor. It takes about 5 minutes because it's already dissected for you. It's just like an elbow where the lateral ligaments are stripped off. It's dissected for you. Just grab the end of it, put it back to the bone. And so that's how I do it, and it's stable, and I don't think it makes it any stiffer because there's not a lot of dissection. Kevin, you talked about scaphoid fractures. We already touched on that a little bit. The issue now that people talk about vascular versus non-vascular treatment for delayed or non-unions. So people say you don't have to do vascular treatment anymore because if you just fix it well, put a graft, it'll heal. Are you on some of them are bad and need vascular treatment, or they're all fixed the old-fashioned way?
I'm firmly in the non-vascular way now. There's a really nice review by Aaron Miller and Jerry Wong from the last year about doing non-vascularized grafts for these, and they really stress the importance of doing the debridement back to healthy bone, which is something that Stevanovic just hammered on all through residency. So all Stevanovic would ever do is put in K-wires and iliac crest. And he actually has a series of 100% unions in smokers and in all these non-unions. So I think debridement is the key.
Yeah, I think you're right. I mean, it's an old operation that's come back. It used to be called a light bulb procedure. Back in the 70s, they just curette out the proximal pole. The only trouble is that you had to use K-wires because there was no place to put a screw in the proximal pole. So once you get to that kind of regressive debridement there's no more screws. Screws are out. So now you're talking about either a scaphocapitate screw temporarily to shut down some of the scaphoid motion, and the rest are K-wires because there's no place to put a screw after you do a radical debridement. All righty. And Nick, it's really the cult of fixing fractures with screws and nails has really happened. But you didn't say a word about the size of the hole in the metacarpal head. Now, K-wires make pretty small holes, 1.6 millimeters, but 3 and 4 millimeter screws or rods or whatever they are There are bigger holes. So you can get back rowing in 2 months, but how are you in 20 years? And nobody knows that question. So what's your gut feeling about that, putting a big hole in the metacarpal?
I guess the better question is, how do we feel about putting a big hole in the scaphoid, right? No one really cares. We just put it in, and no one questions it. If you look at the metacarpal, the dorsal third, when you extend it, it really doesn't engage. You have to hyperextend to get some engagement. If you take a sample, if you take a cadaver, there's the roving van that goes around. Ream through it, look at it. The tendon is really not that affected. If you look at the size of your metacarpal hole, it's actually very minimal. So I really don't think it's going to be clinically relevant 20 years down the line.
Okay. All right. We can put holes wherever we want. And that's the end of it. Michael, so you're talking to your residents and they're hoping they'll send you 2 views. But when you have somebody that has pain in the wrist, and there's always a CT scanner always available in the emergency room. Somebody has pain, focal pain over the scaphoid. Why wouldn't you just tell them to get a few cuts in the scanner while you're right there? It's not a big deal. And there have been studies, there was a British study that showed it cut down on the treatment time a lot and saved a lot of money to not put people in cast that did not have scaphoids.
I have actually gotten pushback from EDs about getting CT scans, so it's not always the case. Yeah, I mean, there's CT scans aren't that expensive, but there's a little bit of a cost factor, and you have to think about how many you're going to find, via that method, and how many CT scans you're going to do. So, I mean, I think if you have a really high suspicion, and it's a matter of timing also, like if you're not going to have OR availability, like if you have it the next day or two and you really need to find the answer out, then sure, go ahead and get it. But if it's going to be, but if you have availability later, then I think it's pretty reasonable to wait also.
Okay. Well, thanks very much to everybody. Very stimulating afternoon.